Hi, I'm James Gagg. I'm one of the A&E consultants here at Musgrove Park Hospital and the clinical service lead.
And I'm Kate Locke. I'm a Senior Improvement Advisor here at Musgrove Park. We're here today to talk to James a little bit about what, just coming back from our Royal College of Emergency Medicine Scientific Conference this year, and about his thinking about that and the work that we've been doing at Musgrove. So do you want to fill us in about what you learnt at the conference?
Yeah, sure. So as usual, it was another really good conference with a broad number of topics discussed, covering a huge number of things such as the current science and clinical trials that have been run across emergency departments throughout the country, a number of which that were taken part in Musgrove. So to take one example, there's the BEST study, which is looking at point-of-care troponins being used in the emergency department. So that's been run by a team in Manchester and is looking at how using point-of-care troponin testing can speed up the management of patients in the emergency department by doing a bedside test rather than having to send samples to the lab. So we got an update on that. The results will be out in the year ahead. But it's the sort of thing which is an example of where research in emergency medicine is looking at how we can improve patient journeys, times that patients spend in the department, and so the overall effect that it has both on the patient and our departments we work in. There are a number of other areas looking at perhaps some of the more political sides of issues today, such as the increase in demands on our services and how we need to develop our services to meet those demands. A good example was a session on managing of the older patients in emergency departments. With an ageing population, this is a hugely growing area of our work, and something needs to be addressed because the needs are different. And this is particularly interesting because it was useful to hear the insights of other experts in this field for what are being done in other hospitals, but to put that in the context of the work we've already done in Musgrove, whereby over the last couple of years we've implemented an older person assessment liaison service, which is some specialist nurses based in the ED with the support of care of the older person consultants, as well as access to rapid access clinics and the resource of the emergency department. And that's been a great benefit to our service with improved turnaround times in the emergency department, getting more patients home from the emergency department, as well as reducing length of stay overall in hospital for these patients.
And is that a common model across the country, do you know?
So these models vary. Many places will have a different model whereby perhaps the frail elderly patients go to a different unit, a frailty unit, to be assessed. But this model we run here, there is still a frailty unit in the hospital, but it's slightly different in the fact that our frailty nurses are coming down. They are based in the ED, liaising with the frailty unit, with the clinics, with the consultants, so that actually they could be picking up patients as they arrive, perhaps before even an emergency clinician has even seen that patient, to start that patient's journey from the time the paramedics have dropped them off.
That's really great. And can you share with us some of the stuff that you were able to share with the conference about what we're doing here at Musgrove? Yeah,
so one of the real successes we've had over the last year has been looking at crowding in the department, which is a huge problem across departments around the country. Part of the work we did earlier in the year was to use the St Thomas's Occupancy project and implement that in our hospital, as well as developing triggers for when we huddle and when we escalate to the hospital to try and get the support and resource that's needed. Doing that, we've created an amber escalation where there's 30 patients in the department, which interestingly is before the department feels too busy, trying to get in there early. And to try and fix things in the department we can. And if demand still increases, when we hit a red escalation at 35 patients, this is getting extra resource from around the hospital to support the department, to improve flow, to try and reduce the occupancy. As we know, occupancy is a real risk factor known to be related to increased inpatient mortality, so it's so important that we do this.
What were the results of doing that?
We implemented this in October last year, and we found in 2 weeks of that implementation we'd had an increase in our 4-hour performance from 90 to 95%.
Excellent. And what about the work around the walk-in patients?
So another area that's really important and also growing hugely is the number of patients who attend emergency departments who perhaps could be seen by other services rather than just emergency clinicians. The Royal College did some work a couple of years ago in the Sentinel Site Survey where it was shown that about 15% of patients could be managed by primary care services, a little more by sort of urgent care services with GPs in emergency departments. And so over the last year we've developed a new model different from the traditional miners model of an emergency department, whereby rather than just having junior emergency physicians seeing the patients who walk in, we've grown our workforce, we've employed a large number of GPs within the department, as well as a 24-hour service with emergency nurse practitioners, physiotherapists and emergency care practitioner. So we've got a breadth of workforce who can meet the needs of the patients who are walking in. And so this model works very closely with the emergency department. It sits in the same footprint as the emergency department and under the same governance structure as an integrated sharing of the workload, so that we can tap into all the resource, all the knowledge of all those work streams to get the best care for our patients. And so that was implemented in April this year. Fortunately, subsequent to the process and staffing changes, we also got the funding for a rebuild, and so the year has seen us also develop an environment which is right for assessing these patients.
That's fantastic. And what has been the results of doing this in terms of the 4 hours?
Yeah, so our current 4-hour performance is now running at around 92%, which is above the national average. It's an improvement on where we were going back a year or two. And I think if we look specifically at the patients attending the integrated front door, we're now running for ambulant patients a performance of 96%. We've got to be really pleased with that.
That's fantastic. Thank you very much, James.
Thank you.